computer, and I'll get started here. So welcome to today's webinar, and thank you for joining us today. My name is Carol Reese, and I am a registered nurse and a nursing advisor with the practice team here at the SRNA, and my role today is to help facilitate the webinar. Before we start, I would like to acknowledge that this presentation is being held on Aboriginal land and recognize the strength, resilience, and capacity of the Treaty 4 and Métis people of this land. Our topic today is the RxFiles, and our presenter today is Alex Crowley, who is with the U of S College of Pharmacy. Before we get started, I have a couple of notes on how you can engage throughout the presentation. As a viewer of the webinar, you'll be able to hear and see the presentation. Only panelists will be able to speak throughout the presentation. If you have a question, please add them to the Q&A or chat sections. We will be monitoring this area for questions throughout the webinar, and these questions will be answered either live or via typed response. If you wish to send your question anonymously, just check the box at the bottom of the Q&A screen. We will be recording this webinar, and it may be posted on the SRNA website for those who are not able to join today to view later. An email will be sent to you with a link for the evaluation. We hope you'll take a couple of minutes to complete this quick survey. And now that we have the housekeeping items out of the way, I'll turn the microphone over to Alex.
Thanks, Carol. So hi, my name is Alex, and as Carol mentioned, I'm at the University of Saskatchewan. So my official title here is the Associate Director of RxFiles Academic Detailing. And it might be useful just really briefly to give you a little bit of an overview of our program. So we essentially get a grant from the government of Saskatchewan to provide education to physicians, pharmacists, nurse practitioners, and nurses as well here in the province of Saskatchewan. And so our kind of big selling feature is that the education we provide, we try to be as unbiased as possible, as balanced as possible, because we don't get funding from the pharmaceutical industry. And so you can see on our website here, rxfiles.ca. So our goal here is objective comparisons for optimal drug therapy. And we have all these charts inside our website and inside a book that we publish here in Saskatchewan. And essentially we're comparing drugs side by side in order to help folks make good decisions on which kind of drugs they might want to be prescribing their patients. And so prescribing is really the thing that we're focused in on, but we have a lot of resources even for folks that aren't prescribing, such as nurses too. And so today I'm just going to talk you through a few of them. And I can see that there's at least a couple of, well, maybe one participant online, so at least somebody's listening, which is great news. So rxfiles.ca, and I'll go to our resources here. These are a couple of the books that we publish, and the one that I want to focus on right now is this RxFiles book. So if you click there, here's the table of contents of the book. And you can see it's a big, thick book, right? We got all kinds of topics. And I wanted to dive into the first one with dementia and behavioral and psychological symptoms. So we'll click on that page here. So you can see we've got a few pages here on dementia and the behavior and psychological symptoms. The RxFiles book I like quite a lot because we've laid it out with the goal of, if you are somebody working in long-term care, or if you are somebody that's doing a medication review on an older adult, what are some of the things that you really want to think about and really want to pay attention to and really want to find useful? So here, for example, if you're thinking about an older adult with dementia who's exhibiting the behavioral and psychological symptoms, and you're reviewing their medications, what are some things you might want to be thinking about regarding their meds? And we set it up kind of as a checklist, actually. So an approach to managing the behavioral and psychological symptoms of dementia. Well, our first check is document the target symptom. Our second check is assess for triggering factors, and so on. So the idea is that you can kind of go through the entire section and you can focus in on the check boxes. And if you're able to check all the boxes, then you hope that you're providing really good care. Interestingly, there's lots of medication triggers, of course, for these behavioral signs and symptoms of dementia, and I find that really fascinating. Right? Sometimes we'll throw an older adult on a drug to help out with their dementia symptoms, but a lot of times it's actually a drug that's causing it. So we're just adding a drug to a drug. one of the interesting things as I've been talking to physicians about this topic is the idea that non-pharmacological interventions are actually more effective than pharmacological treatment. So that was very fascinating to me. And we put this long list together here of all the different, in green here, the non-pharmacological options for psychological triggers. And a lot of them are uncontroversial. Things like reassuring and allowing the individual to make decisions whenever possible. I like a lot, if you are saying, would you like water or milk rather than what you would like to drink? So kind of limiting those choices a little bit to make things a little bit easier for them to understand. And some of those things can just help a lot, so much with the agitation of those kind of behavioral and psychological symptoms. So we like this section a lot. And then we go a little bit into the drugs, and depending on which kind of symptom your patient might be experiencing, then we talk a little bit about what kind of drug might be helpful for that particular symptom, and we list dosing and so on. One thing I want to point out too, this surprises a lot of folks, is that, commonly we'll use antipsychotics, of course, for BPSD, and they are, relatively effective, and you'll get, a response maybe, so the number needed to treat means the number of patients you need to give a medication to in order to see some kind of benefit, and maybe 1 in 5 to 1 in 14 patients might get some benefit from antipsychotics. But one thing I found very, very interesting is the idea that a lot of times after 3 months, you actually may not need that antipsychotic anymore, because some of those symptoms of BPSD may have essentially disappeared. Sometimes those symptoms just kind of wax and wane that way. And the reason we kind of push the idea that, try backing down and see if it works or not, is that there's just so many of these harms associated with these antipsychotics that we're using. So some of the increased weight and hyperlipidemia, so some of the metabolic symptoms, but maybe most importantly, the stroke, right? So the risk of stroke goes up by maybe up to 3 times as much, and maybe even death goes up as well. There was one fascinating study, as I'm scrolling down here a little bit, which showed that if you were able to, it was the HALT trial and the HART trial and the HART-AD trial. So the idea is that if you're able to stop the drug after about 3 months, you'll actually have this mortality benefit, decrease mortality by 25%. And the other fascinating part of this here is that when we zoom in a little bit here, we can see that a lot of folks found that even though they got rid of that antipsychotic drug, they were just as good as the folks who continued on the antipsychotic drug. So no statistical difference at 6 months in most of the important measures. So that was very fascinating to me too. This idea that, treating somebody forever on a drug and not thinking about whether or not that drug is still important or not is usually not the best approach. And so as I just scroll up here a little bit real quick, I think it's potentially very reasonable to try a drug for some of these symptoms, but then just maybe thinking about backing away from it and seeing if it helps. And the thing that I find interesting as well is that a drug like risperidone comes in these 0.25 milligram tablets, right? And so you don't have to go right down from 2 milligrams of risperidone down to 0. You can go from 2 to even 1.75, right? Just a tiny touch down and see if you notice any change. And if you still notice symptoms are exactly the same, you can touch it down a little bit a couple weeks later. And so we go into more detail on that in this kind of deprescribing algorithm. So we got permission from deprescribing.org for these deprescribing algorithms. And the idea behind deprescribing is that, it's useful sometimes to start somebody on a drug, but it's also useful sometimes to stop somebody on a drug too. So if I can click here, this should take us right to deprescribing.org's website where they've got these algorithms here. And so it lets you assess if somebody's a good candidate for stopping one of their medications. It lets you look at, how that tapering might go, how quickly you should taper, all that kind of stuff. So deprescribing essentially is the opposite of prescribing, right? It's backing away on a medication rather than adding a medication in. So really like that section, really like that information on dementia, behavioral, and psychological symptoms. The other part that I wanted to show you guys a little bit is a really useful anticholinergics chart. So I don't see it at first glance, but I'm just going to do a quick little search here. Here it is, the anticholinergics. So here we've collected all the medications that have a risk of anticholinergic effects. And so to quickly review those anticholinergic effects, that they can make somebody a little bit drowsy, a little bit dizzy, a little bit foggy, and so on. In the blue are medications that are a little bit safer. Red, medications that are a little bit more risky in terms of anticholinergic effects. And then green, we kind of highlight maybe potentially preferred options. So we zoom in on antidepressants, for example. Paroxetine in older adults is a drug I really like to avoid, and it's because it's got these anticholinergic effects more than the other SSRIs. And instead, citalopram and sertraline are often fairly preferred options. And so this can be kind of a useful chart if you got a patient and they're a little bit more dizzy, a little more drowsy than you would expect. You can wonder, well, is it their meds that are doing it or not? And here's a nice handy list of all the medications that might be contributing to some of those anticholinergic effects. The Beers 2019 criteria that came out this year suggested that it's okay to have 2 drugs maybe in older adults that are affecting the brain, but once you start getting to 3 or more drugs affecting the brain, that starts to become something you might want to avoid. So not a hard limit, but something to start considering. So let's say somebody's on bupropion, and then they're added nortriptyline, now they're on 2, and then they're added morphine. Well, now they're on 3 drugs that are all affecting the brain. And so we start to worry a little bit about the risk of falls, and we start to worry a little bit about the risk of confusion and all that kind of stuff. We've also got this clinical frailty scale. And so if I click here, this scale is a really nice, quick, easy way of just doing a quick assessment to see how frail somebody is. And frailty is a bit of a nebulous concept, and we go into a little bit of detail in the book. But the idea, of course, is that the more frail you are, then the higher risk you are of having essentially an adverse effect or a side effect from a medication. So somebody who is more frail is more likely to get drowsy on nortriptyline. They're more likely to run into difficulties tolerating bupropion, for example, all that kind of stuff. So I like our clinical frailty scale a lot, and I shouldn't say ours. They've given us permission from Dalhousie to print it in our book here, and I like it a lot because it just lets you do a quick little assessment to find out if somebody might be at risk of a side effect or a higher risk of a side effect from a medication. Another part I wanted to highlight real quick is in our COPD section. So we've got a COPD inhaler technique section if I click on there. So I'll zoom out a little bit. This is a 1-page sheet detailing all these different COPD devices. And there's 2,000 of them out there now, right? So metered-dose inhaler, Respimat, HandiHaler, BreezeHaler, TurboHaler, Discus, January, Ellipta. Those are all the most common ones. We got one more, I should say, the Aerolyzer too, down below. But the vast majority of devices you're going to run into, we've kind of stuffed all this one sheet. And so the idea is that if you're teaching a patient how to use one of these devices, then this is just kind of your go-to sheet for every single device. And we also kind of laid out how essentially it's just a 5-step process for every single device. So preparing the dose, making sure the patient's breathing out, breathing the medication in, holding your breath, and then breathing out. And then we put some comments on the side. And so if you can just kind of keep those 5 steps in your head, then that is kind of all you need in order to teach inhaler technique. And where the drugs really differ, of course, is in preparing the dose, because they all get it prepared in a different way. And then the other big difference is that in some of these dry powder inhalers, like the HandiHaler, BreezeHaler, you need that really hard, fast, deep inhalation. Whereas if you want a metered dose inhaler, Respimat, that slow inhalation is better. And that's just because if you breathe too quickly with these devices here, the drug will just go right to the back of the throat and you won't actually absorb any in your lungs. Okay, so a useful page there. We also put together a page regarding COPD and asthma on how to pick an inhaler. And so this is the concept that kind of the things that differentiate these different inhalers are that some are better for your hands and some are better for your lungs. So to give you a little bit more explanation, the idea is that if you've got really nice, strong hands, like you don't have osteoarthritis or you don't have tremor, then it doesn't really matter which inhaler you pick. But if you do have, one of those conditions, then you may want to get in those weaker hand type devices. So these devices here are just easier to use, a little bit easier to use regarding the hands. You don't have to fiddle. The meter dose inhaler, for example, you got to fiddle around with it. The ResMed, you got to fiddle around with it. You got to time the actuation, all that kind of stuff. But these ones, you just load up the dose and go. So you don't really necessarily have to have strong hands to do it. And then the other concept is that if you have strong lungs versus weak lungs, so if your lungs are in rough shape, like you have really severe COPD, for example, then you might have a really tough time getting the dose out of some devices. So, for example, the turbohaler doesn't show up in this weak lung section because the turbohaler is just really tough to actuate the dose properly. It's got a really really high resistance, they call it. And so since the resistance is so high, it's hard to get the dose out of there. And so you got to have strong lungs in order to manage it. So this is our hands versus lung approach. Kind of a useful chart. Here's another chart page you might find really interesting. So this is what we call our crush list, if I scroll down far enough. So here we go, dosage form alterations crush list. So the idea is that some medications you're able to crush, some medications you're not. And we've got a few tips here on if you are going to alter a medication, how to do it. But then more importantly, we've got a long list of medications here and whether or not you're able to crush them or not. And so if we look at apixaban, for example, we can see here that apixaban has a nice green check mark. And so we are able to crush apixaban if somebody's needing it for their atrial fibrillation. However, dabigatran, also used for atrial fibrillation, we would notice that the bioavailability goes up if pellets are taken out of the shell, or in other words, a patient's going to get a bigger dose if you decide that you're going to open up the dabigatran capsule. And so they actually would be at a high risk of a bleed, and you're better off using a different oral anticoagulant for their atrial fibrillation and stroke prevention. So useful little chart here. It's got all those kind of drugs side by side and describes a little bit if you are going to crush it, how to do it. Do you need to mix it with water? Should you avoid mixing it with water? All that kind of stuff. So that's all I'll say about that page there. Those are kind of some of the big things on the RxFiles, but you'll notice, of course, that there's page after page, right? So those are, to me, some of the pages that are maybe most interesting to a nurse audience. But there's all kind of, if you care about learning about meds and you want to know as much about a med as you can, then that's a good place to go. This other book that we have here are drug comparison charts. So it's a little different than our geriatric one. So the geriatric one, as I said before, really focuses on older adults and how to do a med review in an older adult. And our drug comparison charts are a little bit less specific, and essentially it goes condition by condition. And depending on the condition, how do we compare which drug we might want to pick for a given condition? So we'll pick on the opioids, for example. So here's our opioids chart. So you notice this chart is quite different than some of the stuff in the Geri book. It's busy, it's dense, it's compact. And we do that because we want to compare everything side by side. And the only way to do that is to cram it all on one page. So here's our different opioids, morphine, hydromorphone, oxycodone, and so on. You can see here's the different equivalent doses between them. So we can see that, for example, hydromorphone is 5 times more potent than morphine. Oxycodone is 1.5 times more potent than morphine. MED equals 1.5. So we got the doses over here and the interval over here. So how often to give a dose and what kind of dose is kind of a comparative dose. We also note in our comments kind of how some of these different drugs differ. So for example, the oxycodone, that's one that I don't like oxycodone at all, and it's mainly because there's a little bit more euphoria associated with oxycodone than some of the other ones. So we have this induced diversion concern. So I really don't like oxycodone for that reason. And the reason is that it hits we finally hit this kappa receptor, whereas most of these other ones are hitting the mu receptor. So I think that kappa receptor is associated with more euphoria, and so for that reason I don't really like oxycodone. Similarly, morphine we might worry a little bit about in renal impairment, and so so just kind of move this over to the side here. So we put this little kidney symbol here, and we note here that if you have severe renal dysfunction, then morphine is probably a pretty poor choice, and I prefer hydromorphone in that particular scenario. We talk a little bit about codeine and the fact that codeine needs to be converted, and so codeine also isn't one of my favorite drugs because you need to convert it to morphine in order to get any kind of a dose out of it. And it turns out that some people are quite good at converting codeine into morphine, and some people, their enzymes are quite bad at converting it. And so the short story there is that codeine is a fairly, kind of unpredictable drug in a lot of ways. Because some people will get a bigger dose than you're expecting, and some people will get a lower dose than you're expecting. So codeine, not really one of my favorites for that reason, and we highlight that a little bit there too. Okay, so a lot of busy stuff, like I said, all packed onto one chart. But this is kind of our way of comparing different agents side by side by side. So we'll back out of that one. The other part of our RxFiles that I think you might find interesting is some of our patient education. So we'll click here real quick. So not all of the stuff is ours, but some is. These are kind of our patient handouts that we've collected from around the web that we just find, particularly useful. And a few of these, of course, we've made ourselves. So I want to put on our opioids handout to begin with. So this opioids handout, questions about opioids and the answers that might surprise you. We geared this handout towards patients who might benefit from reducing or stopping their opioid. So the idea is that, well, there's some patients out there who may be on an opioid, they may think it's helping, but maybe their opioid isn't actually helping as much as they expect it is. And so we go through this kind of facts and myths idea. And so the idea is to create a little bit of cognitive dissonance and get people kind of out of their comfort zone. So when they think to themselves, if I take my opioid exactly as prescribed, I won't have any side effects. Maybe they think that's a fact, but when they turn to the next page, we describe why that's actually a myth and how you might have side effects, and sometimes you don't even realize that you're having side effects. And so we've highlighted that here. So facts and myths, and we'll go over here to Rita's story. So this is a patient out of Saskatoon, actually. We changed her name for the book, but we essentially highlighted how she was on an opioid and she thought it was doing good things to her, but when she started backing down on the dose, she talks about this awakening. She talks about how she felt like a person again, and she hadn't realized how much the opioid was actually slowing her down rather than helping her out. And so the idea of putting this patient anecdote in is in a hope of kind of, sometimes people decide they don't want to get vaccinated because they've heard one bad story about somebody getting, they heard somebody getting a side effect from a vaccine, to a second cousin of theirs, and so they decide they don't want to get vaccinated. And so the point I'm trying to make is that anecdotes can be so powerful, and they can, a good story can convince somebody. And so we thought, well, let's put a good story in this little booklet and maybe convince some people that the opioid that they think is helping maybe isn't helping as much as they think. Now, this is a good time to put a little caveat, which is that some people absolutely get good benefit from opioids, and some people it's very appropriate. But other people, of course, are on opioids and probably shouldn't be on opioids anymore. And so this is our attempt to try and maybe change their mind a little bit. If we scroll down, we talk a little bit about some kind of questions about opioids and whether withdrawal is going to happen and how to lessen withdrawal. We highlight some of these side effects that people can have that they may not even realize they're having, and then we put this little puzzle together. So could my opioid be tricking me? And it's the idea that you may back down on the opioid dose and your pain goes up, and you say, well, that opioid was obviously helping me for my pain. But sometimes that's just withdrawal pain, and it's just your opioid kind of tricking you, because withdrawal pain can feel just as bad as the usual pain. And so we kind of put this kind of puzzle together that kind of highlights the way that pain can essentially fool you. And then we have another patient story on the back of the booklet. So we're quite pleased with this one. For a similar topic, we put together this cannabis booklet, and that's another fun one to go through, I think. So questions about cannabis and the answers that may surprise you. So very topical. We got a lot of good response from this particular one. So we call this a booklet for people thinking about starting medical cannabis. And we tried really hard to to thread the needle between making a booklet that both would be useful for the people who should maybe think about starting cannabis, and also for people that maybe shouldn't think about starting cannabis. So we tried to kind of walk that line and try to provide a little bit of a balanced approach. So hopefully this is the kind of booklet you'd give to your patients that you think should and shouldn't be on this particular drug. So we describe different kinds of cannabis, and we do another facts and myths deal. And some of the myths that we highlight is that cannabis works better than most medications. Some types of cannabis don't have side effects. Cannabis has a lower risk of addiction, a low risk of addiction. And all those things are, I think, believed by patients, but there isn't really good evidence to support them. Cannabis, of course, is not particularly well studied. We spent a long time kind of diving into all the literature, and there really isn't a lot of literature out there. But we did feel we could land fairly safely on some of these facts and myths. And the interesting thing for me about cannabis is that I think there are patients that maybe could get some benefit. You know, I'm thinking of somebody that's tried 12 other medications, and they have a neuropathic type of pain in particular, and you know, they're really at the end of their rope, and they're on a high opioid dose, and they want to come down on their opioid dose and try cannabis instead. You know, those are all, to me, kind of good indicators that maybe cannabis could be useful. But we tried to kind of put this document together in order to at least make sure that patients kind of know what they're getting into. So the idea of informed consent, essentially, and the idea that, okay, I realize that cannabis could cause some of these issues, but I still think that maybe cannabis might be right for me. And then, of course, this kind of a hard no for some people. So the idea that people who are pregnant or breastfeeding, people who are younger, people who have had addiction problems in the past, people who have a psychiatric condition. So we kind of put, we would feel comfortable saying a hard no to some of these people in terms of starting cannabis. And then we also wanted to give this kind of big push to the idea of treating illness from more than one direction. And so we've got this car here, and the idea is that, you know, if you had a car with 4 flat tires and you said, well, I want to get going on the road, and so let's say cannabis fills one of your tires, or even any medication fills one of your tires. Well, that's still not enough to get on the road, right? You're still not going to drive with 3 flat tires. And so the idea is that, well, you should also try, psychological therapy and cognitive behavioral therapy. And you should try getting enough sleep and exploring spirituality and eating healthy. And you should try exercise. And essentially, the idea is that treating pain from more than one direction is far more powerful than taking that passive approach and just taking a drug and doing nothing else but take the drug. So we're trying to get that message across a little bit too. And then we put together this kind of do's and don'ts if you are going to start it. And then the idea that, just like opioids, cannabis can sometimes trick you into thinking it's working. There's some recent trials that came out that show that the high of cannabis is quite well linked to the pain relief of cannabis. And so that's always a little bit worrying to me, right? So if you give somebody alcohol, for example, and they said, well, it got rid of all my pain, I felt great, that wouldn't necessarily mean that I think alcohol is a great idea for you and you should take alcohol every day to numb your pain. That maybe isn't a healthy behavior anymore. And so we tried to kind of highlight the idea that using cannabis as an escape is not really the best way to use it. Okay, so that was that booklet. Tons more. I also want to highlight actually these. This book here on tapering sedatives. So this comes from deprescribing.org. So you may be at risk. And the idea behind this one, they actually studied it, and it was called the Empower study. Really fascinating study. I'm gonna pull it up real quick for you here. So the Empower study was just really, really, really interesting, and I'll show you why. So here's what they did. They put together this booklet, and the booklet was the one that I just showed you, this one right here. And all they did is they just basically handed it to patients, put it in the mail, and they didn't even really, this is the wrong study, isn't it? No, it isn't. That's the right one. Sorry. So they just gave patients a booklet, didn't even talk to them about it, just gave it to them. And unbelievably, 62% of the patients that just got the booklet, no conversation, but just had the booklet, went back to their doctor and said, hey, I think maybe I don't need this benzodiazepine anymore. oh my gosh, this booklet right here, you hand it to a patient, there's a good chance they'll come back and talk to their doc or their pharmacist or their nurse practitioner, whoever, that maybe they don't actually need that drug anymore. And then after 6 months had passed, almost a quarter of patients had actually managed to get off their benzodiazepine. So when we talk about appropriate use of medications in Saskatchewan, and making sure that people are on benzos for the right reason, then to me this is just like a mind-blowing, intervention. They did almost nothing. They just handed them this booklet, and they had this massive result. So what's in this booklet? Well, it talks about medications. They use a similar true-false kind of fact myth quiz that we did, and kind of create the cognitive dissonance. And they talk about all these kind of good approaches to help you sleep that are non-pharmacological and don't rely on a drug, and ways of dealing with stress and anxiety. And they put in a patient anecdote, just like we did in our opioid booklet. And kind of this is it, right? So it's a great little tool for telling patients about a medication that maybe they don't need anymore. And again, another candidate, right? Some people really do need their benzo, and benzos can be useful drugs when used in the right patients. But other people, maybe they've been using a benzo for sleep for the last 5 straight years. And whenever I hear that, I always wonder, well, is the benzo really doing anything to you anymore, right? Like the benzo was just there to treat the withdrawal of the benzo if you weren't on it, as opposed to it's actually putting you to sleep. So if you don't take it, you don't fall asleep. But if you were to go off your benzo for a month, you probably wouldn't even miss it anymore because you would get back into your regular sleep habits. So really nice section there. And we got lots in here. So intranasal naloxone, that's a really cool one. I like that one a lot. This smokers who want to quit and smokers who don't want to quit from the Canadian Cancer Society. I really like those handouts, and I've used them successfully on smokers before. So tons of little resources there. I like that page a lot. The other section I want to show you is this articles published in Canadian Family Physician. So if I click here, so a few times a year we will put together these, I say a few times a year, but the last one was August 2018, so we're slacked a little bit. But there will be one coming out in November on cannabis. And the idea behind these ones is it's ways of kind of diving into a therapeutic topic, and we try to take an approach of, well, assume that maybe you're a student or maybe you don't know particularly much about a particular topic. And so we try to kind of explain things from a fairly, big picture, broad approach. So here's our most recent one was on tapering opioids using motivational interviewing. And if I just look at the PDF here, this one was a little bit of a different approach that we used. But the idea is that we go through this conversation that the doctor is having with Mrs. Johnson, and the doctor is just trying to be a good listener and trying to get his points in when he can in order to kind of help Mrs. Johnson realize that maybe her opioid is actually hurting her rather than helping her. And so I think it's a fun little read. I think it's a cool little approach on how to have these kind of gentle conversations with patients and how to not get patients back up when you're having those conversations with them. I'll back out of that one. So we got all kinds of articles. I really like our warfarin one, although it is geared, of course, more for prescribers than for nurses. But this warfarin one is just so when I'm teaching pharmacy students about warfarin, I hand this article, I say, go read it. And then we do some practice cases together. And if they've read the article properly, they'll have a good feel on how to dose and how to monitor warfarin. So I'm quite pleased with that one too. Okay, we'll go back. The next one I wanted to highlight is these newsletters here. So these are our deep dives into therapeutic topics. Some of these maybe won't be particularly valuable to nurses, but quite valuable to nurse practitioners, I would think. And so we've collected all these so basically every year we tend to do 2 of them. Sometimes we do 3. And they're just kind of our deep dives into something like antibiotics, for example. So here's our antibiotics newsletter from back in 2017, and we've collected basically all the most important stuff we can find on antibiotics in Saskatchewan, on resistance rates, and when to use a particular drug and when to avoid, when you probably don't need a drug and when you should maybe even use 2 drugs and all that kind of stuff. And so this is kind of our big dense newsletter on antibiotics in general. So tons and tons of stuff in that. And so these are often a deeper dive these kind of newsletters than what's found stuffed into the chart pages of our book. So that our big kind of, often 16 pages or 13 pages or whatever, kind of highlighting a particular topic in great detail. And diabetes is the one that's coming next. So probably in about 2 weeks, we should have our diabetes newsletter up online as well. Okay, so the trial summaries and the Q&As, these are when we take clinical controversy and dive into them, or when we take a trial and dive into that. So these are very interesting, but I don't think I'll go into too much detail here. I'll pull up one up real quick. So here's a Q&A on vaccines and whether or not older adults should get, for example, the high-dose Fluzone or not. And so we kind of talk a little bit about the controversy around it and what does the evidence say and so on. Here's topical cannabis. We did this one recently. So should we put cannabis on the skin? And if we do that, or should we actually expect anything or not? And kind of the bottom line is, well, it's completely unstudied. Who knows if it works or not? And so that's kind of our little section there. So Q&A is kind of interesting. Trial summaries, these are really dense ones. So the Accord Advanced trial, for example, Accord versus Advanced, excuse me, this is comparing these two major diabetes trials side by side. So lots of big information here, but we'll back out of there for now. Okay, here's where you might be thinking, well, I kind of like some of this stuff, so how do I have access to it? So access to RxFiles in Saskatchewan, we can click here. And we put together a little bit of a YouTube video on how to connect through SHRP and so on. So we won't play that video today. You can go click on that another time. But the short story is that there's SHRP.usas.ca. So it's this, I spelled it wrong, SHIRP.usas.ca. So it's the Saskatchewan Health Information Resources Program. And basically, if you are a healthcare practitioner in Saskatchewan, then you have free access to SHRP, although you do have to sign up. So if you have heard of SHRP before, awesome. But if you haven't, you really should check it out. It's a really terrific collection of resources. So I'm going to scroll here to request a SHRP user account. And so you can just fill in your name, and you fill in your profession, and you fill in where you're working and all that stuff. And then they will quite quickly shoot you access to SHRP. And then once you have access, you can click on RxFiles, for example, and you'll have access to RxFiles. Or you can click on, go back here real quick, or you can click on Nursing Central and you'll have access to that. Now, I got to tell you, I don't know anything about Nursing Central, but I bet you it's really good. And so maybe some of you guys are using it already, I'm not sure. Let's see if I should have my password there. So we can click here, and you've got all these kind of guides to drugs and calculators and all kinds of stuff. So SHRP is an amazing resource, and through SHRP, you get access to our resources as well. So just kind of a heads up that's there. I'll just kind of finish things off, and then we'll open up for questions if there are any. And if there aren't any, then you can go to enjoy your lunch or whatever. I'll just kind of quickly finish this off by going back to our drug comparison charts. So these charts can be really difficult to read, and they can be really, really dense and so on, and tons of topics. But one place to click is the symbols, colors, pregnancy categories. And so if we click here, we get all the abbreviations we use, and we also get all these kind of different symbols that we use throughout the chart that save space, and if you know them, then it makes your life easy. So for example, our kidney symbol means that you have to adjust the dose for renal dysfunction. Or our liver symbol means you got to adjust the dose for the liver dysfunction. Or we also really like whether or not a drug is covered in Saskatchewan. We use these symbols here to show that somebody has Saskatchewan drug coverage. We use these kind of pregnancy symbols here, so the green, the lighter green, the orange, and the red to describe how safe a particular medication is in pregnancy. And so if I go back and if I pull up, let's say, our angina chart, then you can see that we got all these pregnancy symbols describing how safe each of these different medications for medications for angina are in pregnancy. And so I might feel quite comfortable, for example, using nifedipine rather than using amlodipine in somebody who is pregnant. A caveat, of course, is be really uncommon for somebody to have angina and be pregnant, right? That's kind of older lady rather than younger lady's disease, but we do kind of put them there just in case. And, pneumonia would be a good example to look for the pregnancy symbols for younger adults. Okay, so that's lots of talking for me. I'm not sure if there's going to be any questions, but if there are, really happy to hear them. We'll just kind of go from there. And if not, we can wrap up a little bit early, and that's great too. So over to you, Carol.
Thank you, Alex. Wow, what a lot of information and a lot of fantastic information. Thank you so much.
You guys are probably a little stunned now, hey?
It's a little overwhelming to look at initially just like that, but I think it's a fantastic resource. The amount of information that's contained in there can only help somebody's practice. I can't see it being a bad thing. Might take a little while to wade through it, but I think you would absolutely be delivering safe patient care.
Well, the thing that we really like about our resource too for Saskatchewan, that's all Saskatchewan based, right? So our drugs are, we describe if they're on a Saskatchewan drug plan, or we describe, whether or not a dose is approved in Canada or not, rather than just America. So we kind of like that Saskatchewan focus.
Yes,
yeah.
absolutely.
Yeah,
yeah, I know, in my past, when I was working at the bedside, I would, excuse me, often look up resources and lots of times get US information. So, I mean, I think this is fantastic. It's Canadian, it's Saskatchewan focused. I think it's absolutely something that every nurse, no matter what her practice is, where she works, should be accessing it, because there's some absolutely fantastic information there that I think is essential for safe patient care. So thank you so much.
Yeah, great to hear. Yeah.
Does anybody have any questions for Alex? We have 6 attendees with us right now. I'm just wondering if anybody has any questions. If I noticed a couple of you came in a little later, this will be recorded and put onto our YouTube channel, so there's always an opportunity to go back and review anything you may have missed. Tell your colleagues. Like I said, there's some fantastic information here. Yeah, I'm doing a little work right now with some nurses up north, so I'm kind of excited to pump this one up and deliver it to them and show them this is what you can be using for your practice. So,
well, that's great to hear. Thanks, Carol.
Yeah, you're welcome. Nothing from anyone? You're all busy on your computers now, looking it up and trying to figure out what you're going to print.
They're probably eating their lunch like sane people.
That could very well be too. Doesn't look like anyone has any questions, but if we do get any, if anybody has any questions, you can always send them to us at Practice Advice. And if it's something that really is Alex's area of expertise, we'd be more than happy to pass it on to him and then get back to you with some answers, or have him get back to you and share out this information. Oh, I got one. Is there pediatric Rx files?
Well, it's a very good question, yeah. So we actually get that question a lot. We like the idea of writing a pediatric RxFiles one day, but we have not written one yet. Yeah, so there's the geriatric one, and hopefully one day there'll be a pediatric one too. We do go into a little bit of pediatric stuff in our regular book. So here we got a pediatric pain chart if I click here, and we've got all kinds of information on pediatric pain. And then, of course, our asthma chart, if I click on that one, has tons of pediatric information on asthma, if I can find it. Yeah, here we go. So our asthma chart describes doses for younger kids and what a high dose is for some of these inhaled steroids and what a low dose is and all that stuff, and kind of how to step up therapy and what ages these drugs are indicated in. So fluticasone, for example, you can use in greater than 1 year, but if you're going to use cyclosinide, you should really wait until it's 6 years according to Health Canada. So kind of useful information as well. But in terms of a dedicated resource, pediatrics, not yet. I really would like to do one day, yeah, and I think we will once we get enough. Yeah, once we get there, we'll get there.
Well, and I imagine with the Children's Hospital just opening up there in Saskatoon, I'm sure there will be somebody wanting something like this for the pediatric population. So
yeah, I think there's potential there for a partnership as well. I completely agree. Yeah.
Yeah. Okay, anyone else? The other 5 are pretty quiet. Okay. I think we're probably done, Alex. Thank you again so much for this. It's been great. Lots of information. And next week, our topic for our webinar will be tools for resolving professional practice issues. And as I said, if you've missed the webinar, you can always see it on our YouTube or Vimeo channels. And thank you again, Alex. We really appreciate you bringing this information forward.
This is my pleasure. Thank you so much, and have a great day, everybody.
Yes, you too. Thank you.